بسم الله الرحمن الرحيم. محاضرة اليوم هي آخر محاضرة بالدنتال مانجمنت أوف سيستميك ديزيز واللي تتعلق بالسكين ديزيز. حقيقة راح ركز على السكين ديزيز اللي إلى oral administration in the with other system in the body of the skin. What mean dermatology? Dermatology is study of skin disorder. The importance of dermatology. Systemic disease have cutaneous manifestation, also mucous membrane, including oral mucosal membrane. Some dermatosis may be preceded by oral lesion, gendermatosis, hereditary skin disorder, vesicular-bullous disease, skin disorder characterized by presence of vesicle or bullae. هذه هي كل ما يتعلق بالسكين ديزيز اللي هي معناها dermatology تعرفناها، فهو skin disorder that effect of the skin and the mucous membrane in the one of the mucous membrane that have its important feature is the oral cavity, the mucous membrane of the oral cavity. Most of the diseases under the heading of vesicular bullous are caused by reduced action of antibodies by patient autoantibodies. They are directed against various constituents of molecular apparatus that hold epithelial cells together or that bind surface epithelium to the underlying connective tissue. إذن كل ما يتعلق بالreaction as a vesicle or bullous that occur that نتيجة reaction antibody-antigen reaction to the epithelium or the underlying tissue or connective tissue. The ensuring damage produced by the interaction of these autoantibodies with the host tissue is clinically seen as disease process, often termed as immunobullous diseases. إذن كل ما يتعلق بالbullous or vesicle that occur in the epithelium or underlying the epithelium هي نتيجة autoantibody antigen antibodies reaction اللي تصير that occur in the skin or any mucous membrane of the cell. Some term نستفاد منها بالskin lesion هي أول شيء blister. What mean blister? I will define the blister. A fluid-filled cavity formed within or beneath the epithelium, epidermis. That means that the first layer of the skin is epidermis. If any collection of fluid under this layer, call it blister. عندنا vesicle وعندنا bullae. Vesicle is elevated blister containing clear fluid that are under 1 centimeter in diameter. إذا كانت blister more than 1 diameter of the centimeter diameter راح نسميها vesicle. إذا bullae elevated blister lake lesion containing clear fluid that are over 1 centimeter in diameter. إذا صارت البليستر أكثر من 1 centimeter in diameter راح نسميها bullae. إذا الفيزيكلز هي بليستر ولكن diameter أقل من 1 سنتيمتر. البولاي هو بليستر ولكن diameter أكثر من 1 سنتيمتر diameter. نبدي بالأول disease هو PEMPHIGUS. PEMPHIGUS is serious chronic skin disease characterized by appearance of vesicle or bullae, a small to large fluid-filled blister on skin as well as mucous membrane that develop in cycle. Derived from a Greek word, PEMPHIGUS, bubble or blister, mean Greek word bubble or blister. أول من اكتشفها هي ويشمان in 1791. It affects 0.1 to 0.5 patients per 1,000 population per year. حقيقة هي البيمفيغاس هي كلمة لاتينية إغريقية جاية من bubble or blister. That formation as a vesicle bullae in the skin or mucous membrane of any part of the body. It's characterized by histologically by interepithelial slift and immunologically by finding of circulating IgG antibody directed against the cell surface of keratinocyte. نلاحظ بالهيستوباثولوجي histological feature هي وجود a cleft space between epidermis or dermis and the underlying structure. هذه نتيجة IgG antibody reaction راح تسوي destruction للهيميديسموزوم or desmosomes that connect the epidermis or dermis to underlying structure. There are three primary substances, three categories for pemphigus: the pemphigus vulgaris, pemphigus vegetanus, pemphigus folliculus, and paraneoplastic pemphigosis. هي ثلاثة والرابعة راح تكون precancerous lesion of the skin or mucous membrane. عندنا pemphigus vulgaris, pemphigus vegetatus, and folliculus هي pre-substance, and the other one is a pre-malignant lesion. نبدي بالpemphigus vulgaris. It is an autoimmune interepithelial blistering disease affecting skin and the mucous membrane and is mediated by the circulating autoantibody directed against keratinocyte cell surface. These autoantibodies bind to keratinocyte desmosomes and to desmosomes-free area of keratinocyte cell membrane, especially keratinocyte cell surface molecule, desmoglein 1 and desmoglein 3. The binding of autoantibodies result in loss of cell adhesion. The pathophysiology of the pemphigus vulgaris. احنا عندنا الهيميديسموزومز اللي تربط to epithelial cells with other structure, the basal membrane, and desmosomes اللي يربط between two epithelial cells. The desmoglein 1 and 3 that connect this desmoglein and desmoglein 3 connect the epithelial cell to the adherent to the epithelial tissue. The desmosomes are adhesion proteins that function both as an adhesive complex and as a cell surface attachment site for keratin intermediate filament KIFS of the cytokine. This forming the connection between the epithelial cell and basal. The pemphigus, this actinothylaosis that breaking this connection between two epithelial cells and by IgG antibody anti-inflammation that correct and forming the space or clifting between and the tissue underneath the desmosomes, that connection that is not be a connect between epithelial cell and with the basal cell of the epithelial tissue of the skin or mucous. Antibody binding may activate complement with the release of inflammatory mediated and recurrent of activated T cell. حقيقة راح يصير inflammatory action between antibody antigen reaction وأدينا activated of T cell. Other factor, there are PV has genetic vulnerability like diet, garcelic that effect on the epithelial tissue, or drug like penicillium and catepril and rifampicin and diclofenac that effect on the epithelial cell. Other etiological factors like virus, herpes simplex infection, other pesticide, estrogen hormone that affect on the tissue surface. Other factors associated with other disease like rheumatoid arthritis, myasthenia gravis, lupus erythematosus, pernicious anemia, all affect at to the pemphigus vulgaris. The clinical feature of pemphigus vulgaris, it affects all races with equal gender distribution, age of onset between 50 to 60 years. There is rapid appearance of vesicle and bulli varying in diameter from few millimeters to several centimeters. This lesion contains thin, watery fluid shortly after development, but this may become purulent or spongious when bulli rupture. They leave a raw, eroded surface. This figure shows the small intact vesicle on the labial mucosa of the upper lip, and other area affected is the eye. Involvement of the eye a few days later with conjunctivitis and conjunctival vesicle. There is a small vesicle on the upper eyelid. This occurs in the upper or lower eyelid. If become large intact vesicle on the skin area, the erosion lesion of the posterior buccal mucosa that have lead to erosion, the vesicles that by the occlusion of the teeth that become as ulcerative type. What mean Nikolsky sign? Nikolsky sign, the loss of epithelium associated by rubbing apparently unaffected skin is termed Nikolsky sign. That is, a bulla can be induced on normal appearance skin mucosa if firm lateral pressure is exerted. This is caused by a prevascular edema which disturbs dermal-epidermal junction. 50% of patients have oral muco lesion before the onset of cutaneous lesion by 1 year and are very difficult to resolve with therapy. The first to show and last to go. And then the first thing you show it, but last one go by the treatment. This figure shows the blister formation on normal appearing gingiva after movement of the mirror handling under pressure, indicator of positive Nikolsky sign. حقيقة إذا نحرك الميرور على الميوكوزا راح يصير البليسترينج وهي Nikolsky sign. Virtually any oral mucosal lubrication may be involved: lateral, labial mucosa, buccal mucosa, ventral surface of the tongue, and gingival mucosa. Other signs being pharynx, larynx, esophagus, conjunctiva, cervix, urethra, and anal mucosa. Pemphigus can be associated with the thymoma, lymphoma, Kaposi sarcoma. This figure shows the multiple erosion affecting the marginal gingiva by the Pemphigus vulgaris. Erosion of the dorsum of the tongue of the dorsal surface can be as erosive like in the blindness as Pemphigus vulgaris. This figure shows multiple erosion of the left buccal mucosa or large irregular shaped ulceration involving the floor of the mouth and ventral of the tongue. All the oral mucosa can affect by the Pemphigus vulgaris. Other area that affect the ocular lesion, the upper or lower eyelid, that by vesicles and the rupture and forming the mucus as a fluid, clear to fluid that have go from the eye. Now, the Pemphigus vegetatus, second part of the Pemphigus or vegetatus. It is an uncommon variant of Pemphigus vulgaris, occur in 1 to 2% of Pemphigus vulgaris cases. Median age between 40 to 50 years. There are two clinical subtypes of Pemphigus vegetatus: exact, flaccid bulli, and erosion and postulus. This is two criteria of the Pemphigus vegetatus. Both subtypes develop into a hyperpigmented vegetative plaque with postulus and hypertrophic granulation tissue at periphery. A characteristic feature of Pemphigus vegetatus is the cribriform tongue, characterized by a pattern of sulci and gyri on the dorsum of the tongue. This figure shows the vegetation lesion on the buccal mucosa and commissure of the upper and lower lip in the angle of this junction between them, that forming as a white and ulcerative lesion. Oral manifestation of pemphigus vegetatis involve mucus in 50 to 70% of patients. Intact villi are rare in mouth. Ill-defined irregularly shaped gingival buccal or palatine erosion, which are painful and slow to heal. Erosion extends peripherally with shading of epithelium. Erosion seen on any part of oral cavity. Erosion may involve larynx with subsequent hoarseness. Patient is unable to eat or drink adequately because the lesions are so uncomfortable. Other mucosal surface may be involved, including conjunctiva, esophagus, vagina, cervix, penis, urethra, and anus of the mucosa of this area in the body. This histopathology of the pemphigus vegetatis, an interepithelial cleft suprabasilar split is located just above the basal layer, and the rounded acinoisis epithelial cell sitting within the interepithelial cleft, called transic cells. We can see this cell between the basal cell of the epithelium and the epithelial layer of the skin and the mucous membrane. We can see hyperchromatic zinc cell in the cell histopathology of the pemphigus vegetatis. There are marked inflammatory cell infiltration, positive zinc cell cytological test. It is for diagnosis of pemphigus vegetatis. Do cytological test, we can see the positive zinc test. Immunofluorescences demonstrate the presence of immunoglobulin, predominantly IgG, but sometimes in combination with C3, IgA, IgM. Direct immunofluorescence, frozen section of patient tissue. Indirect immunofluorescence, patient serum. We can do this for immunofluorescence tests. Paraneuroplastic pemphigosis, first described by Anhalt et al. In 1990. Diagnostic criteria: painful mucosal erosion, sometimes with skin eruption that eventually resulting in blister or erosion in the setting of confirmed or ocular malignancy. Acanthosis and keratinocyte necrosis that occur in every malignant lesion. The DIF typically reveals of IgG and complement C3 within the epidermal intercellular space, as well as at the epidermal basement membrane. IDF reveals circulating antibodies specific for specified squamous or transitional epithelial is found. Immunoprecipitation of a complex of protein with typical molecular weight. These are autoimmune response to intercellular adhesion as Pleckens. Mortality rate is 90%. Cause of death including sepsis, multi-organ failure, respiratory failure. This leads to death in any case of pemphigus. Clinical features: age at 16 years, between 7 to 76 years. Male more equal to female, with little exception. All patients had tumor, malignant non-Hodgkin lymphoma at 84%. The conjunctival ulceration is frequently featured. Existence of neoplasm is recognized prior to eruption of lesion only about two-thirds of the cases. Other associated malignancy include the chronic lymphocytic leukemia, 8%, the Castleman tumor, 80%, giant cell lymphoma, reticular cell sarcoma, Waldenstrom macroglobulinemia, 1.2%, thymoma, 5.5%, poorly differentiated sarcoma, squamous cell sarcoma of oral cavity, the bronchogenic sarcoma, squamous cell sarcoma, follicular dendritic cell sarcoma. Oral manifestation. Painful oral lesions are accompanied by generalized cutaneous eruption. Eruption assume form of more form and uretical bullous, bulbosquamous or erythema multiforme like lesion. Pruritus, pain, erosion can occur on buccal, labial, lingual, mucosa, and gingiva. Erosion and crusting are similar to Sjogren syndrome, SG syndrome. Nose, pharynx, tonsil can be affected. Nasal ulcer may cause epistaxis. This figure shows the lesion in the eye and in the mouth. In the eye, the ocular involvement as an ulceration of the upper and lower lid. In the oral cavity, these diffuse oral ulcerations are quite painful. Rusted and hemorrhagic lip. Polymorphous cutaneous lesion again occur in the skin. This feature as histopathology of paraneoplastic pemphigus. This lower four photomicrograph shows both interepithelial and subepithelial clifting. We can see the R spacing between the base of the basal layer of the epithelium and the epithelial layer. Other form of pemphigus, pemphigus folliculus, is discovered by Kazinski in 1844. It is an autoimmune skin disorder characterized by superficial blisters, positive Nikolsky sign, little or no involvement of mucous membrane. It includes 6 subtypes: Pemphigus erythematosus, Pemphigus herpetiformis, Pemphigus endemic, Pemphigus follicularis, immunoglobulin AGA, Pemphigus follicularis, paraneoplastic Pemphigus follicularis, drug-induced Pemphigus follicularis. Formation of autoantibodies directed against a cell adhesion molecule, desmologin 1, expressed mainly in the granular layer of epidermis. Clinical feature: early bullous lesion which rapidly rupture and dry to leave masses of follicles or sclera, suggestion of exudative dermatitis or eczema. It's a relatively mild form of pemphigus, more common in older adults. Site rare in oral cavity, lower extremity, and abdomen. Brazilian pemphigus, Brazilian wildfire, found in tropical regions, particularly in Brazil, Colombia, Bolivia, Venezuela, Tunisia, occur in children and frequently in family group. Oral regions are rare. Femoral rod construction are affected due to arthropods or infective organisms. Very severe scaling blisters are not appeared. Pemphigus erythematosus, eruption of the subauric area that consists of malar lesion. Butterfly eruption of the skin. The scaly black to purple or to vesicles. This figure shows the superficial crusting on petal area of the face, butterfly appearance of the face. The asymmetrical disruption of red erupted crusted lesion. Thin roof vesicle leaf eroded and crested lesion. localized erosion on the dorsum of the tongue of the affected patient. Histopathology that have the hyperkeratinosis, acanthosis, subcoronal vesicle disc keratotic, dermatological hemocyte infiltration. Now we go to other topic, pemphigoid. Pemphigoid is a relatively uncommon vesicular bullous lesion characterized by histologically by subepithelial bulli formation in the basement membrane zone. The pemphigoid clinically similar to pemphigus, oid similar to similar histological feature as prognosis is different. حقيقة البامفيجويد هو يكون ما بين الابيثيليال tissue and the connective tissue beneath the basement membrane. Pathogenesis, formation of autoantibody in the body against the antigenic component of basement membrane zone, binding of autoantibodies of hemidesmosome associated antigen in the basement membrane. حقيقة راح يكون ما بين الهيميديزموزوم اللي تربط بين البيزمنت membrane with the epithelial cell. As you see in this figure, Y is IgG and DSG3 and desmoplakin and keratin filament plasma membrane attachment block. All this figure shows how the pemphigoid occurs. The schematic diagram of dermosomal ultrastructural change in the BV model mucosa. In non-acantholytic area, the desmosome on the apical side of basal cell are thus in the supra-basal layer were intact, and the majority of BV IgG was deposited at the extracellular portion of the desmosome. As in A, both DSG3 and desmoplakin show no significant change in their localization. In addition, NOP desmosome like structure lacking attachment block and keratin filament insertion indicative of keratin retracted desmosome were seen on the lateral side of the basal of keratinocytes. In B, within the acantholytic area, numerous split desmosomes were seen at the blister roof as well as the floor. They were decorated with anti-DSG3 IgG on their extracellular surface and keep connection with keratin filament via desmoplakin. And in C, an equidesmosome-like structure were also seen in the acantholytic area at lateral surface of the basal keratinocyte. In this figure shows how it occurs in the cell of tissue. Current concept of the immunopathogenesis of PEMPHIGUS antibodies against DSG1 and DSG3 induce loss of keratinocyte adhesion in PF and in PV. Respectively, DSJR constitute of the desmosomal plaque that interact with the cytoskeleton keratins via cytoplasmic component of the desmosome. Glycoglobin PG and desmoglobin DP upon binding of the autoantibodies to desmosomal target antigen. TNF alpha and interleukin 1 are released from epidermal keratinocyte, which presumably enhance the process of blister formation in contact with the site-activated proteases. Plasminogen activator, phosphophilips C. Antibody produced by B cell depend on the health of the Th1 cell for IgG1 and the Th2 cell for IgG4, IgA, and IgE autoantibodies. Autoreactive the Th1 and Th2 cell recognize epitosis of extracellular portion of DSG1 and DSG3, mainly in the context of BV-associated HLA class 2 allelase. HLA DRP beta 1 multiply 0.402 and DP1 beta 1 multiply 0.503. DSG3 reactive cells that recognize antithetical epitopes are also found in healthy carriers of the aforementioned by BV-associated HLA class 2 allelase. There is a predominance of DSG3 reactive the Th2 cell in BV and of autoreactive the Th1 cell in healthy individual. In addition, TR1S specific for DSG3 are present at higher frequencies in healthy individuals than in PV patients. Thus, an imbalance of appetitive relationship between autoreactive Th and TR1 cell may be critical in pathogenesis of BV. Hence, DSG specific TR1S may be critical for the maintenance of tolerance against DSG3 and DSG1 in healthy and the restoration of tolerance against this autoantigen and limited PV extract from the article. This diagram shows the activation of the complement lead to synthesis of chromatographic factor. This lead to release of proteolytic enzyme, and this lead to destructive hemodosomous junction of the basement membrane zone. This formation of subepithelial vesicle or bulli. Unlike pemphigus, pemphigoid lesion usually heal by scar formation, cicatrification. Cicatricial pemphigoid, bullous pemphigoid, cicatricial pemphigoid in relation to the mucous membrane, while bulli pemphigoid occur frequently in relation to the skin. The cicatricial pemphigoid, benign mucous membrane pemphigoid, clinical feature, it frequently affects the middle-aged or elderly females. The most common site of occurrence in the oral mucous membrane, followed by the conjunctiva. Sometimes the disease also involves the nose, pharynx, larynx, esophagus, and genitalia, etc. Oral lesion. Oral lesion begin as either vesicle or bulli, most commonly involving gingiva. In the severe cases, large vesicle or bulli may develop on the palate, cheek, alveolar mucosa, or tongue, etc. Bulli are sometimes quite large in size and they persist for several days. Gingival lesions often show erosion and desquamation after rupture of bulli and leave eroded bleeding surface even for weeks or months. Chronic desquamative gingivitis. The mucosal bulli are often tense and are relatively tough because they are usually covered by full thickness epithelium. Moreover, these lesions remain intact for several days. Pain and bleeding are the common complaint, and Nikolsky sign is positive. This figure shows the eye lesion and the oral cavity, like the adhesion and called semi-peripheral between the bulbar and papillar conjunctiva. Upper eyelid turn inward, entropy, resulting in eyeless wrapping against the eye tracheostosis. Severe conjunctivitis, lower eyelash are removed because of tracheostosis. Complete scarring between conjunctival mucosa and the eyelid, resulting in blindness. Eye lesion starts with conjunctivitis, then blister formation in the eye, corneal ulceration that often lead to blindness, swelling of the fornix and corneal obesity, fibrosis and scarring of lacrimal duct, which often lead to dry eye. Scarring may cause adhesion between the bulbar and the palpebral conjunctiva. Skin lesion. Skin lesions occur in about 5% of the cases, and mucosal lesion always precede the skin lesion. There are tense, fluid-filled vesicle or bulli which may appear over the face, scalp, or neck. The critical pemphigoid, as in figure, critical pemphigoid in a patient with more advanced ocular scarring, not the thickening of the lid margin, shortening of the conjunctival sulcus, and scarring the eyelash have been ablated after interruption development. Bullous pemphigoids occur more commonly on the skin, seldom affect the oral mucosa. Clinical features: this lesion also follows the usual clinical pattern of vesiculation followed by ulceration and finally healing without scarring. Elderly people in the age around group 70 to 80 years are usually affected, and there is no gender predilection. The skin lesions mostly occur on the turn and limb and usually undergo spontaneous regulation. Skin lesion begin as red eczematous plaque, which eventually progress to formation of bulli. Skin lesion always precede the mucosal lesion, and these mucosal lesions are always smaller than that of the critical pemphigoid. Bulli pemphigoid having oral lesion may be associated with internal malignancy. Histopathology of this lesion: extracellular edema and vasculation in the basement membrane zone are the earliest histological change in the critical pemphigoid. Gradually, there is formation of subepithelial vesicle or bulli. The subepithelial bulli cause separation of the full thickness epithelium from the underlying lamina propria. Acantharosis and epithelial degenerative change are absent. Polymorphous nuclear neutrophil may be found within the vesicular fluid. Blood vessels are often dilated and prominent in the superficial part of the lamina propria. This figures histopathology that we can see mucous membrane pemphigoid. The photomicrography of mucus demonstrates lack of the red vega and loss of the adhesion of the epithelium, which change at the level of the basement membrane. We can see in these two figures the histopathology and round of histopathology that we can see the basal cell and clefting between basal cell and subcellus cleft or connective tissue split between them and formation of the subepithelial connective tissue show inflammatory cell infiltration by lymphocyte, macrophage, and eosinophil in the perivascular area. Now we go other feature of the skin lesion is the erythema multiforme. Erythema multiforme is an acute inflammatory dermatological disorder that frequently involves skin, mucous membrane, and sometimes the internal organ, characterized by rising of iris target lesion. اللي يميز الارتيما multiforme هو مثل iris target lesion on the skin lesion. There are two forms: erythema multiforme minor, erythema multiforme major. Erythema multiforme minor, localized eruption of skin with mild or no mucosal involvement. Erythema multiforme major, Stevens-Johnson syndrome, more severe, potentially life-threatening skin and mucosal involvement. عندنا ناحيتين هي erythema multiforme minor and erythema multiforme major اللي نسميه Stevens-Johnson syndrome. Etiology of erythema multiforme: the first infection, tuberculosis, herpes simplex 1 and 2, infection, mononuclear histoplasmosis. Other etiological factor: drug hypersensitivity, barbiturates, sulfonamide, phenylbutazone, salicylate, oral pills, etc. Hyperimmune reaction, miscellaneous factor, radiation therapy, Crohn's disease, vaccinations that lead to erythema multiforme. Clinical feature: They frequently occur between the age of 15 to 14 years, male more than female. Rapidly developing erythematosuses inclusion popular vesicle or bulli often appear symmetrically over the hand, arm, leg, feet, and face and neck. This the classic dermal lesion of the erythematoform, which often appear on the extremity, are called target iris or bulli target أما نسميه target أما نسميه iris or bullous eye lesion. The dermal lesion consists of constructed erythematous ring separated by a ring of near normal color on the skin. Mucosal lesion of this disease also consists of mucosal papilla or vesicle, etc., and most is seen on the tongue, palate, vocal mucosa, and gingiva. This is two forms of erythematoform, the ulcerated lesion or hemorrhagic characteristics on lip. The vesicles of the mucosal surface are often short-lived and they readily become eroded or ulcerated and bleed profusely. The ulcers are extremely painful and are not normally covered by slough. They can be secondarily infected in many cases too. Foul smell in the mouth and difficulty in eating and swallowing. The cutaneous and mucosal lesion may occur either separately or simultaneously. Trachea, brachial ulceration, and pneumonia, uncommon among children and older individuals. However, if it occurs in older people, the possibility of an internal carcinoma should not be ruled out. Take time to love. It is the secret of internal years. Thank you for your listening or your attention.